As you likely know, there has been a huge push both nation and statewide around diabetes care and diabetes outcomes. HRSA has instructed primary care associations around the country to focus on diabetes outcomes as training opportunities for health centers. The Diabetes Roadshow was modeled after the colorectal cancer screening roadshow that the Montana Primary Care Association had last fall. MPCA sponsored Rachel Dorland Roan, a registered dietitian nutritionist, licensed nutritionist of the Bighorn Valley Community Health Center in Hardin, to travel around the state to various community health centers in hopes of improving diabetes outcomes and other chronic disease outcomes through both clinical and non-clinical partnerships in community health center communities. Hi, my name is Rachel Dorland Roan. I'm a registered dietitian nutritionist at Bighorn Valley Health Center, providing services at our Hardin and Ashland clinic sites. Today I will present Integrated Patient-Centered Diabetes Care, a shared vision. I will discuss the steps we have taken to engage, enable, and empower our patients and community around diabetes care and prevention. Diabetes imposes a substantial burden on society in the form of higher medical costs, lost productivity, premature mortality, and intangible costs in the form of reduced quality of life. The cost of care for people with diabetes now accounts for 1 in 4 healthcare dollars spent in the U.S. After adjusting for inflation, economic cost of diabetes increased by 26% from 2012 to 2017 due to the increased prevalence of diabetes and the increased cost per person with diabetes. Care for a person with diabetes now costs on average of $16,750 per year for people in the United States. It is estimated that there are approximately 30 million people living with diabetes in the U.S. today, with numbers easily reaching 55 million by 2030. As practitioners of community health centers, we must hone our root cause analysis skills and connect individuals with the resources they need, as we know many factors play a role in diabetes-related health. For instance, did you know the odds of emergency department visits or hospitalizations were increased more than 5-fold for individuals with housing insecurity? We must consider factors of economic stability, social context, physical environments, and access to healthcare, food, and education. Diabetes care in the United States consistently has failed to meet recommended quality standards. Collected data reveals significant quality gaps in the treatment of diabetes and in screening for diabetes-related complications. Nearly 1 in 5 diabetics has poor glycemic control, more than 1/3 have elevated blood pressure, and more than half of diabetic patients have elevated LDL cholesterol levels. Diabetics also do not receive the appropriate screening measures. Only 28% receive the recommended HbA1c measurements more than once yearly, while just 55% obtain an annual foot exam and 63% submit to an annual dilated eye examination. Outpatient care for diabetes exemplifies the challenges of and the opportunities for chronic disease management. Involving patients in their own care, particularly with regard to education and self-management, can improve health outcomes as well as diabetic patients' quality of life. However, the quality gaps that persist in the treatment and secondary prevention screening processes demonstrate the pressing need to improve adherence to standards of care in both of these areas. Using quality measures from your QDI reports is a great place to start when planning programming around diabetes care and prevention. The huge gap between ideal and actual diabetes care is not surprising. Diabetes management is complex. Our healthcare system is more acute care oriented and not well equipped to meet the needs of chronic disease management, which requires a focus on self-management support, patient engagement, team-based care, and population management. A critical component of a medical home practice is that members of a well-tuned healthcare team work together through effective coordination and communication to cultivate and promote a culture of teamwork, which leads to improvements in patient-centered care, including diabetes care. The delivery of evidence-based care is safe, easily accessible, and affordable, with each patient having a personal physician or provider who leads a team to ensure that the care is coordinated across specialties and providers. The team has a whole person orientation with attention to not only medical, but psychological and social needs. The patient-centered medical home is looked upon by the health delivery system as a continuous quality improvement journey, as it is ever changing to meet the needs of patients. We all have a great foundation on which to build an effective diabetes program. As practitioners of a diabetes care team, it is important to remember the patient is the most important member of their healthcare team. After all, they are the one who's affected by diabetes and cares for it every day. Only they know how they feel and what they are willing and able to do. They do the exercise, they make and eat the foods on their meal plan, they take the medicine or inject the insulin, they check their blood sugar levels and keep track of the results, and of course, they are the first to notice any problems. We, as a healthcare team, depend on patients to talk to us honestly and tell us how they feel and what they need from us. This will allow us to individualize care to not only truly engage the patient in the self-management, but to connect them to the resources they need, or that enablement piece, to achieve the highest level possible of health and well-being, or that empowerment piece. With this level of care, our patients become their own healthcare advocate. They become invested in health and well-being and encourage others to do the same. The 3 phases of diabetes care. Pre-planning for diabetes visits helps ensure that both patients and practice staff are prepared for diabetes visits. Ideally, pre-visit preparation starts at the end of the current visit. Patients schedule appointments for the next visit, which if not at goal may be in 3 months, and arrangements are made for A1C labs to be drawn just prior to the next visit or at point of care, along with other labs to ensure opportunity for timely treatment adjustments. This way, the provider and patient have all the relevant information at hand to review, discuss, and adjust therapies at the face-to-face visit, compared with trying to coordinate a time to review the lab results a few days later. This approach saves time and allows for better communication between the patient and the provider. The process of pre-visit preparation involves the following steps. Proactively identify patients who are due for diabetes visits. Contact patients with clear instructions. Prepare patients to be active participants in their diabetes visits. Use standardized encounter forms to organize information prior to the visit, and integrate strategies for relaying information to practice team members prior to patient encounters. The diabetes visit should be guided by the physician, making sure that the patient's concerns and needs are addressed and relevant clinical and behavioral data are obtained. Warm handoffs can be utilized during the visit to meet patients' individualized needs and enhance value-added care. Warm handoffs can be planned during the team huddles or can be initiated based on the needs of the patient identified during the visit. It is important to develop a system for the end of the patient encounter that supports careful review of the after-visit summary to ensure that patients understand and can execute their care plans and goals, including a plan to order labs just prior to their next visit. This review should be supplemented with patient education materials and referrals to community resources, as well as referrals to specialists as appropriate, to aid patients in their diabetes self-management and support at recommended intervals. It is particularly important that patients leave the office with a clear understanding of medication management, especially for newly diagnosed patients and those with medication or therapy adjustments. Engaging patients as active participants in their disease management decisions is an important method to encourage adoption of and adherence to treatment recommendations that align with patients' needs and preferences. Evidence-based patient-centered approaches to facilitating engagement include shared decision-making, motivational interviewing, and goal setting. Each of these approaches or techniques addresses a unique aspect of patient engagement and disease management support during the diabetes visit and can be applied to pre- and post-visit communication as well. Central to all is the importance of collaboration between patients and healthcare professionals to negotiate diabetes-related decisions. In the context of diabetes care, a sound shared decision-making approach first requires that healthcare professionals be informed of current treatment recommendations and that patients receive guidance when choosing treatment options. It is important for all diabetes care members to be on the same page so patients are receiving consistent messaging throughout their visit. A motivational interviewing style of communication can be incorporated into routine patient care. It has been applied to diabetes to encourage patients to discuss behaviors associated with self-management, as well as to assist patients in their motivation and confidence for making changes that will improve their diabetes control. Goal setting is a valuable strategy for improving self-management skills among patients with diabetes. The American Diabetes Association and the American Association of Diabetes Educators strongly advocate for goal setting as an effective means to support self-care. behaviors related to diabetes. Self-care behaviors include healthy eating, being active, monitoring, taking medications, sleep health, stress management, problem solving, and reducing risks and healthy coping. Diabetes care team members play an important role in understanding patients' motivations to make change, helping them set achievable and measurable behavioral goals, and guiding them through barriers and challenges that may come in the way of meeting those goals. As we know, patients may not meet treatment goals for a variety of reasons. What's important from a primary care perspective is to seek continued engagement with the patient. Population management can serve as a valuable resource for systematically identifying patients who are poorly controlled and bring attention to patterns of control, assuming they come in for routine or somewhat routine visits and have their lab work done. Proactively contacting patients provides the opportunity to encourage patients to schedule a visit with the appropriate clinician to reassess a treatment regimen and identify other factors that may be interfering with or negatively influencing a patient's ability to meet their treatment goals. Such factors may include changes in income or insurance coverage, increases in diabetes-related distress, depression, other health conditions, or competing demands. Validated assessment tools can help identify and assess changes in these factors, including diabetes-related distress, self-efficacy, self-care activities, and medication-taking behaviors. Once identified, the healthcare team can work with the patients and address the barriers, either directly or through referral to other medical or community resources. Other practitioners such as pharmacists, podiatrists, optometrists, dentists, mental health practitioners, and counselors can have a significant impact on diabetes management and should be considered as important partners to the primary care team. Developing strategies for facilitating coordination of care with non-traditional practitioners and partners can help ensure a comprehensive approach to supporting patients in their diabetes management. Patient navigators, care managers, and care coordinators may serve as a useful resource for linking patients to appropriate healthcare providers. The way your practice coordinates services with other practitioners will depend on the availability of local resources. Patients live, work, and play in social and physical environments outside of the healthcare system. Therefore, clinic community partnerships are key to building community support for diabetes self-management. Increasing patient access to effective community resources through linkages with relevant agencies and organizations is a cost-effective way to obtain important services such as nutrition counseling or peer support groups. Furthermore, clinic community partnerships have demonstrated benefits at the individual, organizational, and community levels. Community partnerships may be very traditional services that can extend to health practices patient care, help patients who have special needs such as blindness or limited resources such as no transportation, be very non-traditional yet supportive such as beauty and barbershops that may have access to very hard to reach populations. Shoe stores may partner to raise foot care awareness, and faith-based organizations can offer support group opportunities. To achieve community culture change, it is important to fully assess your community to understand the impact the following may have on health and well-being. Active living, clinical and community linkages, foundational skills and practice, health equity, healthy eating, healthy and safe physical environments, schools, social and emotional wellness, target populations and settings, tobacco-free living, workplace health, resources, and of course, policy. You must also identify key stakeholders to make change possible and to prioritize areas of focus. I believe community culture change can start in your own organizations and grow as your community partnerships are developed. Community partnerships not only improve patient outcomes, they are becoming the basis for funding options. They not only want 1 or 2 partnerships and grant applications, but are looking for 3 to 5. This helps ensure sustainability of projects and impacts the project reach in the community. 10 steps to create community partnerships include identifying community-based team members, identifying needs and aligning with resources already available in your area for patients, their families, and medical staff. It is important to ensure that you are not duplicating services unless increased services in that particular area are needed. Pooling resources and highlighting what each partner does best is beneficial for our patients and our communities. Creating new partnerships to create new resources. This can be done by conducting brainstorming sessions with your healthcare team, asking questions such as, what are your needs now? What might they be in the future? Are there any gaps in available community services or resources? Assess the situation using data collected about your patient population. Identify community resources to fulfill your needs and update your assessment as you learn more. Next, explore ways to listen to community members' diabetes and diabetes care needs. Next, make the resources accessible. Do not just hand out patients a list of resources. Work with the health system to coordinate planning and referrals. Link patients to community resources by a designated staff person. Develop supportive programs and policies with community organizations so they can contact patients and know how to refer back to the healthcare system when problems are identified. Next, formalize the policy to make sure it survives staff turnover. Next, you'd periodically review your community partnerships. Strive to identify new partnerships so that they can be developed to fill the gaps in needed services and really strengthen the partnerships that you already have. Next, think broadly. Partner on a local, state, and national level. Don't miss an opportunity. Contact local officials about your needs. Local officials may include the mayor, sheriff, district health officers, health departments, legislative officials, state diabetes control programs, or representative from the NDEP, the Centers for Disease Control and Prevention, the National Institutes of Health, ADA, AADE, and the American Heart Association, or the pharmaceutical industry. Next, think collaboratively. Link with large and small employers for work-based diabetes self-management support programs. Next, support your community. Volunteer as a guest lecturer, visit a school health program, or participate in community events. These actions can go a long way to show your support for community activities. Next, pursue public policy to support healthy lifestyles. Local and state health policies, insurance benefits, civil rights laws for persons with disabilities, and other health-related regulations play a critical role in chronic illness care. Advocacy by medical organizations on behalf of their patients can make a difference in developing community support for health self-management behaviors, especially those related to healthy eating and increased physical activity. Individual resilience involves behaviors, thoughts, and actions that promote personal well-being and mental health. People can develop the ability to withstand, adapt to, and recover from stress and adversity, and maintain or return to a state of mental health and well-being by using effective coping strategies. Community health resilience is the ability of a community to use its assets to strengthen public health and healthcare systems and to improve the community's physical, behavioral, and social health to withstand, adapt to, and recover from adversity. Why is resiliency important for diabetic patients? Studies in people with diabetes have shown that high levels of resiliency are related to lower A1C levels, indicating better glycemic control. Some people are lucky enough to be born with a high level of resiliency, but even if they are not, they can boost their resilience by making or developing connections, maintaining or developing those good relationships with close family members and friends, so they can accept their support and in turn offer their support. Accept that change is part of life, accepting circumstances that can't be changed and instead focus on circumstances that you can alter. Taking decisive action. When there are situations you can change, take action. Don't detach from problems, just wish they would go away. Keeping things in perspective. Even when facing difficult situations, try to consider the situation in a broader context and keep a long-term perspective. Avoid blowing small things out of proportion. Maintaining a hopeful outlook. Cultivate an optimistic outlook and expect that good things will happen in your life. Try visualizing what you want rather than worrying about what you fear. I think it is really important for patients to really see themselves as a fighter instead of as a victim of circumstances, and really cultivating that attitude of gratitude and counting what you have to be thankful for. So, and of course, this helps have them help take care of themselves. They can do this exercising regularly and eating a healthy diet, meditate or join a faith community, engage in activities that you enjoy and find relaxing. it helps our patients really to be able to better cope with challenges when they're mentally and physically strong. So throughout all program planning and delivery, I weave in activities to develop a more resilient mindset and have participants practice resiliency building skills. A comprehensive diabetes programs includes diabetes support groups. These are facilitated by clinic staff and/or a diabetes champion from the community, focused on problem solving and coping skills, and are patient-client led. By this I mean the clients develop the group rules, they choose the educational topics, and they also choose the topics of discussion. Basic diabetes education is another integral part of a comprehensive diabetes program. They're free to the community, they're open to individuals with diabetes and family members and caretakers, and they're focused on the basic diabetes information and building a diabetes support network. Right now at BVHC, we are using the DEEP program. Comprehensive diabetes education treatment includes medical nutrition therapy, diabetes self-management education, training, and support. These can be offered on the individual level and/or in groups. And it's really focused on providing that consistent messaging throughout our programs. And last but not least, diabetes prevention. We are now using the CDC's prevention program. We're focusing on at-risk screenings, and it's really important before you start a program to really know what those criteria for program referrals are. To get the program up and running and to keep it going and to have that conversation and communication between lifestyle coaches and providers. It really helps with adherence to the program and often leads to more accountability and success for patients. I believe most of you received these questions prior to the presentation today. If not, take a look above and gather some information. Then ask yourself, were you surprised by any of the findings? Did you identify any gaps in your integrated care team? How about the resources in your community? Did you identify any possible community partnerships? And last but not least, how do you plan on strengthening your diabetes program in the future? Thank you for attending the Diabetes Roadshow presentation. Any questions, contact Courtney with Montana Primary Care Association. Once again, thank you so very much.